Welcome to our second and last video on diseases of the heart muscle. Let's begin. In this lecture, we'll discuss hypertrophic obstructive cardiomyopathy and myocarditis. For each condition, we're going to talk about its definition, pathophysiology, causes, clinical presentation, diagnosis, and management. Let's start with hypertrophic cardiomyopathy. Hypertrophic obstructive cardiomyopathy is characterized by asymmetrically hypertrophied myocardium, leading to diastolic dysfunction. Hypertrophic non-obstructive cardiomyopathy, on the other hand, is characterized by symmetrically hypertrophied myocardium, also leading to diastolic dysfunction. In either case, hypertrophic cardiomyopathy leads to heart failure with preserved ejection fraction. Hypertrophic obstructive cardiomyopathy is caused by concentric hypertrophy of the myocardium, which means that the sarcomeres are added in parallel. This leads to decreased ventricular chamber size and therefore decreased ventricular diastolic filling. Additionally, interventricular septal hypertrophy causes left ventricular outflow tract obstruction, which results in low stroke volume and cardiac output. Here you see the illustration of sarcomere changes associated with concentric and eccentric myocardial hypertrophy. As we already explained on the previous slide, concentric hypertrophy is caused by sarcomeres being added in parallel. This leads to decreased ventricular chamber size and reduced ventricular diastolic filling. This is in contrast to eccentric hypertrophy. Eccentric hypertrophy means that the sarcomeres are added in series, which results in dilation of the heart chambers and thus dilated cardiomyopathy. Here's an illustration of hypertrophic obstructive cardiomyopathy. On the left is a normal heart with appropriately sized chambers. On the right, note the enlarged or hypertrophied interventricular septum. Notice how this hypertrophy creates an obstruction on the left ventricular outflow tract, which impairs cardiac output and leads to the clinical features seen in this disorder. Hypertrophic obstructive cardiomyopathy can be caused by an autosomal dominant mutation affecting sarcomere proteins like the myosin-binding protein C or beta-myosin heavy chain. On the other hand, the most common cause of hypertrophic non-obstructive cardiomyopathy is hypertension. This is an illustration of a sarcomere with its components. Please note that hypertrophic obstructive cardiomyopathy is most commonly caused by an autosomal dominant mutation in the gene that codes for either myosin-binding protein C or beta-myosin heavy chain. This is in contrast to the TTN mutation affecting titin, which is seen in patients with familial dilated cardiomyopathy. Hypertrophic obstructive cardiomyopathy is commonly accompanied by syncope during exercise. This is because perspiration during exercise decreases intraventricular volume and further exacerbates the left ventricular outflow obstruction. Hypertrophic obstructive cardiomyopathy is characterized by systolic crescendo-decrescendo murmur at the left sternal border. The crescendo-decrescendo murmur results from the dynamic obstruction of the left ventricular outflow tract by the interventricular septum and the mitral valve leaflet. Patients with hypertrophic obstructive cardiomyopathy also have chest pain and shortness of breath. This is due to increased myocardial oxygen demand as a result of myocardial hypertrophy. Lastly, sudden cardiac death due to arrhythmias like ventricular tachycardia or ventricular fibrillation may be seen as well. Let's revisit this image again to see how preload affects the symptoms of hypertrophic obstructive cardiomyopathy. You can imagine that if you fill up the left ventricle with blood, you will stretch it out and thereby prop open the left ventricular outflow tract. On the other hand, if you empty the left ventricle, it will shrink up, thereby closing down the outflow tract even more, which will lead to exacerbation of symptoms. Hence, these patients need a sufficient volume of blood in the heart to keep their left ventricular outflow open, which makes them very preload dependent. Patients with hypertrophic obstructive cardiomyopathy often have a positive family history for sudden cardiac death at a young age. The main imaging study used in the diagnosis of this condition is echocardiography. Echocardiography will reveal the interventricular septal hypertrophy towards the left ventricle. Additionally, patients with hypertrophic obstructive cardiomyopathy commonly have a systolic anterior motion of the anterior leaflet of mitral valve. This has two hemodynamically significant results that can be visualized on echocardiogram. First, the anteriorly displaced mitral valve leaflet and the interventricular septum obstruct the left ventricular outflow tract during systole. Secondly, separation of mitral leaflets during systole leads to mitral regurgitation. Although myocardial biopsy is almost never done to diagnose hypertrophic obstructive cardiomyopathy, it would reveal myofibrillar disarray and fibrosis. Knowing this finding is actually high yield for the boards. Here is a myocardial biopsy specimen from a healthy patient on the left and one with hypertrophic obstructive cardiomyopathy on the right. You can appreciate that on the left image, the muscle cells and myofibrils are organized parallel to each other. Additionally, there is no fibrotic region. On the right side image, you can see the myofibrillar disarray and fibrosis. Let's talk about the management now. First, one should screen first-degree relatives of the patient for hypertrophic obstructive cardiomyopathy because this is an autosomal dominant condition. Management of hypertrophic obstructive cardiomyopathy includes lifestyle modifications like avoiding strenuous exercise and dehydration. This is because strenuous exercise and dehydration can exacerbate the left ventricular outflow tract obstruction. Pharmacologic therapy includes beta blockers and non-dihydropyridine calcium channel blockers like verapamil and diltiazem as second-line agents. Refractory cases can be treated with an implantable cardioverter defibrillator to prevent the sudden cardiac death. Additionally, the surgical procedures used for the hypertrophic obstructive cardiomyopathy include myomectomy, alcohol ablation, and heart transplantation. Myomectomy and alcohol ablation are procedures that are used to decrease the size of the hypertrophied interventricular septum in order to decrease left ventricular outflow tract obstruction. How can the murmurs of the hypertrophic obstructive cardiomyopathy and the aortic stenosis be distinguished on the physical exam? The murmurs of both hypertrophic obstructive cardiomyopathy and the aortic stenosis both present as crescendo-decrescendo murmur. However, there are subtle differences between them. The murmur of the hypertrophic obstructive cardiomyopathy is best heard at the left sternal border, while the murmur of aortic stenosis is best heard at the right upper sternal border. Additionally, the murmur of the hypertrophic obstructive cardiomyopathy gets softer with the physical maneuvers that increase the preload like elevation of the legs. This is because leg elevation increases venous return and widens the left ventricular outflow tract. In contrast, the murmur of aortic stenosis gets louder with the physical maneuvers that increase the preload. This is because the increased left ventricular and diastolic volume creates more turbulence at the aortic valve. Let's wrap up this lecture by discussing myocarditis. Myocarditis, as the name implies, is characterized by inflammation of the myocardium. Inflammatory infiltrate in the myocardium results in cell death. Release of intracellular antigens then activates the immune system, which then further exacerbates the cardiac damage. Myocarditis can eventually result in dilated cardiomyopathy if the inflammation and damage is prolonged. It's high yield to know the causes of myocarditis. Let's first discuss the infectious causes of this condition. Viral infections are the most common causes of myocarditis. The most common virus implicated in myocardial inflammation is Coxsackie B virus. Other common viral causes include adenovirus, HIV, human herpes virus 6, and parvovirus B19. Common bacterial causes include Staphylococcus aureus, streptococcal species, Borrelia burgdorferi, Mycoplasma pneumoniae, and Corynebacterium diphtheria. Finally, parasitic myocarditis is frequently related to Trypanosoma cruzi or Toxoplasma gondii. Autoimmune diseases implicated in myocarditis include sarcoidosis, systemic lupus erythematosus, polymyositis, dermatomyositis, rheumatic fever, and Kawasaki disease. Finally, some of the drugs that can cause myocarditis include doxorubicin and cocaine. Clinical features of myocarditis include fever and chest pain. Patients may also experience shortness of breath, arrhythmias, and tachycardia. If dilated cardiomyopathy develops due to chronic myocardial inflammation, patients can present with signs of heart failure like peripheral edema, jugular venous distension, pulmonary edema, and so on. The patient's history is essential to diagnose myocarditis. We should consider previous infections, exposure to toxins, autoimmune diseases, and drugs when suspecting myocarditis. Erythrocyte sedimentation rate, ESR, and C-reactive protein, CRP, will be discussed as nonspecific signs of inflammation. Troponin levels are often severely elevated due to myocardial necrosis. Echocardiography may reveal global heart dilation with or without a decrease in the ejection fraction, depending on the severity of myocarditis and the extent of myocardial injury. If a patient with myocarditis has a low ejection fraction on echocardiography, it means that myocardial inflammation has caused dilated cardiomyopathy. Finally, myocardial biopsy is the gold standard test for diagnosing myocarditis. However, it is not commonly performed in clinical practice due to its invasive nature. This is the myocardial biopsy specimen from the patient with viral myocarditis. Here you can see these small, dark blue cells scattered in the myocardium. This finding represents the lymphocytic infiltrate commonly seen in viral myocarditis. The management of myocarditis focuses on treating the underlying condition, whether it's infection, autoimmune disease, toxin, or drug exposure. We should also treat concomitant heart failure with medications like ACE inhibitors, beta blockers, and diuretics. Lastly, it's high yield to know that we should avoid using NSAIDs in treatment of myocarditis. This is because NSAIDs may exacerbate myocardial inflammation and necrosis. Here is the table summarizing all the conditions that we discussed in this and the previous lecture. Please pause the video and take a moment to consider this table. A 15-year-old boy is brought to the physician by his mother due to episodic shortness of breath and chest pain for the past year. His symptoms worsened as he started the basketball training. He passed out during a training session a week ago. His vital signs include a temperature of 36 degrees Celsius, blood pressure of 100/80, heart rate of 86, and a respiratory rate of 15. Physical exam reveals a systolic crescendo-decrescendo murmur at the left sternal border and a holosystolic murmur at the apex. Echocardiography shows an ejection fraction of 60%, along with an asymmetrically enlarged interventricular septum and mitral regurgitation. Dysfunction of which of the following is the most likely cause of this patient's condition? A. Myosin-binding protein C, B. Titin, C. Frataxin, or D. Tuberin. This patient presents with episodic shortness of breath and chest pain for the past year. His symptoms worsened after he started basketball training. The physical exam reveals the systolic crescendo-decrescendo murmur at the left sternal border consistent with hypertrophic obstructive cardiomyopathy, and a holosystolic murmur at the apex consistent with mitral regurgitation. Hypertrophic obstructive cardiomyopathy is confirmed by the echocardiography finding of an asymmetrically enlarged interventricular septum. Hypertrophic obstructive cardiomyopathy is an autosomal dominant condition commonly caused by dysfunction of sarcomeric proteins such as beta-myosin heavy chain and myosin-binding protein C. So the correct answer is option A. Here is the slide reminding us of the causes of hypertrophic, obstructive, and non-obstructive cardiomyopathies. Let's discuss why other options are incorrect. Option B, Titin, is incorrect because Titin dysfunction is usually seen in familial dilated cardiomyopathy. Dilated cardiomyopathy is characterized by low ejection fraction. This patient, in contrast, has the normal ejection fraction of 60%. Option C, Frataxin, is incorrect because frataxin dysfunction is seen in Friedreich's ataxia. Friedreich's ataxia is characterized by hypertrophic non-obstructive rather than obstructive cardiomyopathy. Additionally, the patients with Friedreich's ataxia have other manifestations such as absent deep tendon reflexes, hammer toes, diabetes mellitus, kyphoscoliosis, and so on. All these findings are absent in this patient. Finally, option D, Tuberin, is incorrect because tuberin dysfunction is seen in tuberous sclerosis. The patient with tuberous sclerosis presents with cardiac rhabdomyoma, ash leaf spots, shagreen patches, or periungual fibromas, just to name a few. All these findings are absent in this patient. And that concludes our lecture on diseases of the heart muscle.